Hello everyone, I'm Dr. Riya. I'm from India. I'm really sorry about my voice today. I'm not keeping well. So today I'll be presenting three interesting cases related to the pericardial effusions. These are very interesting cases. I hope you like it. So my title is Unusual Phases of Pericardial Effusion. So we'll go to the case one. The case one is a 34-year-old woman who came to our ER. She was 20 days post cesarean section, and she had come with dyspnea associated with cough since 15 days, which was progressive in nature. Over a week, the dyspnea had produced from NYHA class 3 to 4. She had orthopnea, and she had a history of high grade fever associated with chills since 3 days. And she had a history of Cox contact positive. Her father had TB 15 years ago, and she was in contact with her father. So on presentation, patient had hypotension, tachycardia, and tachypnea. BP was around 80 by 40 millimeters of mercury. Pulse was 125, and she was maintaining saturation of 80% on room air. Her respiratory rate was around 50 per minute, and her JVP was raised. So due to the elevated respiratory rate and low saturations, we decided to electively intubate her. This was her. So her ECG showed sinus tachycardia, ABG was hypoxic, and she had metabolic acidosis. And the 2D echo showed massive pericardial effusion with signs of tamponade. This was her X-ray on presentation. You can see the cardiomegaly on it. This was her echo on presentation. You can see there was a large pericardial effusion. These are just other views of the 2D echo. So patient underwent pericardiocentesis under all aseptic precautions. This was the color of the pericardial fluid. This was the first aspirate that we took. So it was basically frank pus on aspiration. Around 600 ml of fluid was aspirated. So on fluid analysis, in cytology, so all in all, the routines were negative. Only thing to focus here was just a second. Okay. So you can just notice that her pericardial fluid culture was suggestive of methicillin resistant Staphylococcus aureus, which was sensitive to meropenem, vancomycin, and levofloxacin. On her routine fluid analysis, LDH was more than 13,300 and ADA was 110. She had 8 to 10 RBCs per high power field and 22,000 WBC. So patient was started on IV meropenem vancomycin as per culture sensitivity reports, and HRCT chest and abdomen pelvis CT was done, which were normal. This was post-pericardiocentesis 2D echo. We had drained almost all of the effusion. That was her X-ray. Even after starting her on higher antibiotics, as per culture sensitivity reports, the patient's WBC counts were still on the higher side. She was not responding to the antibiotics. She had her D-dimer was on the higher side. So she was showing all the signs of sepsis. The patient had underwent a cesarean section, and from that we took a swab from that site, and that site was infected. It showed MRSA. In her blood culture also there was MRSA. We gave a CTVS call for insertion of pericardial drain because the discharge was very thick and purulent, and we were not able to drain it satisfactorily via the pigtail. Patient was extubated. She was maintaining on minimal O2 support. And then after 5 days of extubation, patient suddenly developed breathlessness, started requiring non-invasive ventilatory support. So then we performed a bilateral lower limb AV Doppler, which was suggestive of deep vein thrombosis in the right external iliac and common femoral vein. On her CT pulmonary angiogram, it showed segmental and subsegmental pulmonary embolism. Patient was started on anticoagulations, and she was kept in the ICU for 13 more days, and she gradually improved. These were her treatment. So because there was a high ADA, LDH, and there was a positive history of COX contact, we initiated an anti-tubercular treatment along with the antibiotics, and to which the patient showed dramatic response and she improved. There was no more aspirate on the 8th day after the insertion of drains. So the drains were removed, WBC started coming to normal, sepsis resolved. And on 25th day since admission, we were able to successfully shift her out of the ICU, and we discharged her on oral antibiotics and ATT and colchicine, and she still remains healthy, stable, and her baby is healthy and she's still on follow-up with us. Her AKT is completed last month, and she's doing quite well. So a few lines about purulent pericardial effusion. So it is a life-threatening form of pericarditis. It is caused by bacterial infection of the pericardial space, leading to accumulation of thick pus-like fluid. Relatively uncommon, but it carries high morbidity and mortality risk. And if not diagnosed and treated properly, it can be deadly. Incidence rate overall is less than 1% of all pericarditis, and hospital-based rate is around 3 to 6% in developed countries. And in HIV endemic and poor healthcare access countries, it can go up to 20 to 30%. Etiology is Staph aureus most common, Staph pneumoniae, and gram-negative bacilli like E. coli, Mycobacterium tuberculosis, and fungal infections. Routes of infection would be hematogenous from sepsis, pneumonia. So in our patient, most probably the route of spread was hematogenous because of sepsis. Direct extension from lung abscess, empyema. Iatrogenic could be post-surgery, post-pericardectomy, and secondary to trauma. Prognosis, the mortality is definitely high, 20 to 30%. If untreated, nearly 100%. And early recognition and drainage of an antibiotic improves the outcome. So when to suspect tuberculosis in a purulent effusion? So first is clinical setting. If the patient is young, immunocompromised, or postpartum, history of chronic fever, weight loss, and night sweats, known TB contact or history of pulmonary TB or pleural TB. On fluid analysis, grossly purulent does not rule out TB. ZN stain is often negative because it has a low sensitivity. High ADA and interferon gamma supports TB, and culture PCR or gene express CBNAT may confirm it. The course, there could be a lack of response to broad spectrum antibiotics, subacute or recurrent course despite drainage, and on imaging, there can be concomitant mediastinal lymphadenopathy or lung lesions and pleural effusion. Coming to case 2. This is a 20-year-old girl with dyspnea on exertion since 2 months. She has a prior history of admission and pericardiocentesis 2 weeks earlier when she came to us. On arrival, the vitals were normal, clinical examination normal. Chest X-ray was showing a mass near right heart border, and ECG was suggestive of sinus tachycardia. Heart rate was around 110 per minute, sinus rhythm. So this girl, she had a history of pericardiocentesis 2 weeks back in a outside hospital in her village, and there she had undergone a full workup. Her pericardial fluid was studied. It showed around 1 lakh RBCs, and she was labeled as an autoimmune pericardial effusion. She underwent a CT scan of chest, and somehow the diagnosis was missed on that CT. So on chest X-ray, you can see there is a big mass over the right heart border. This is the mass. This is a 2D echo. And on 2D echo also we could see a mass which was around 36 by 59 mm seen near the right atrium. These are the other views of her. She had a moderate amount of pericardial effusion also, but she was not in tamponade. So we decided to manage her medically. And basically, we were just waiting for her to go into tamponade. This was her CT. So on chest CT to evaluate the mass, so there was a big mass over RARV. It was seen infiltrating the right atrium and ventricle. And this is the video. So I think it will be a more clear view on the CT video. So it was a huge mass, around 8 by 5 by 3.9 centimeters. and it was extending from D5 to D10 vertebral body. It was compressing the adjacent structures. It was abutting the root of aorta, and it was encasing the proximal aspect of SVC as well. So our radiologist gave us a differential on the CT as angiosarcoma, extracardiac anteromediastinal neoplastic etiology, and rhabdomyosarcoma. We went ahead with a PET CT. On PET CT as well, we can see the mass, and mainly we did a PET CT to rule out if there was any other metastasis in the body or not, and there was no evidence of metabolically active disease anywhere in the body. These were her labs. All in all, it was normal. Blood type was AB positive, and she had a dropping hemoglobin. So then after that, we did a cardiac MRI as well, and a CT guided biopsy, and these all confirmed the diagnosis of a high grade cardiac angiosarcoma. The cardiac angiosarcoma cases are around 650 reported all over the world. On cardiac MRI, we got a clearer report. We saw that the mass was encasing the right coronary artery, approximately 360 degrees, with sparing of distalmost segment of RCA in the proximal AV groove. And the proximal RCA just distal to its origin was also spared for a length of around 1.5 centimeters. There were few intraluminal endophytic growths which was seen within the right atrium, and so basically it was invading the right atrium as well. It was abutting the aorta, and it was encasing the SVC. So during the admission, patient went into cardiac tamponade. She underwent a repeat pericardiocentesis, and around 700 ml of blood-red fluid was extracted. And she remained stable throughout the procedure. And obviously, ultimately, she underwent CT guided biopsy after the drainage of the effusion. This was her echo before pericardiocentesis. It was a very rapidly filling effusion, and this was the color of the fluid that was extracted. On fluid analysis, there were around 1 lakh RBCs. In cytology, the smear was suggestive of blood. We could not get a clear picture of malignancy on cytology, but any which ways we went ahead with the biopsy, and CBNet, MGIT, everything was negative. On histopath, ultimately we got the definitive diagnosis. It was a high-grade angiosarcoma. These are the histopathological slides. As you can see, there are giant cells. There are some foamy macrophages intermixed in the background of cardiac muscles. This is the normal cardiac muscle. This is the tumor. And these are the tumor cells that are arranged in the anastomotic vascular channels. A dedicated, detailed team discussion with cardiologists, cardiac surgeons, radiologists, oncologists, and patient family was carried out. Since she was a very young girl, because of extensive invasion of the tumor in adjacent structures, surgery was deemed as a very high risk for this patient, and so it was decided to go ahead with a tumor-reducing chemotherapy. She was started on IV paclitaxel and other supportive treatments. So she underwent 16 cycles of chemotherapy. Recently, her cardiac MRI was done 15 days back, and it shows the tumor has reduced in size to 4.1, 6.3, 6.5 centimeter, which was previously 8.9, 7.2, and 8 centimeters. She is still to receive 6 more cycles of chemotherapy, and then she is planned for a tumor excision surgery. She's currently stable and is on regular follow-ups. Just to note, there are no set chemotherapy guidelines for primary origin angiosarcomas. The incidence is very rare. It's around 0.001 to 0.03%. This particular case was discussed in multidisciplinary meetings with cardiology, cardiac surgeons, and oncology experts from over Mumbai and all over India as well. And ultimately, the paclitaxel-based regime was selected for her treatment. So a few lines about primary origin cardiac angiosarcoma. The incidence and epidemiology, it is extremely rare. Tumors are around 0.01 to 0.03% in autopsy series. Malignant cardiac tumors make up around 25%, with angiosarcoma being the most common malignant type. And predominantly, most common site is always right atrium, more than 80%. And it is often infiltrating pericardium, RA, and RV. Management approach is always multidisciplinary. as I said. If it is localized and resectable, there should be complete excision to be carried out with adjuvant chemo plus radiation or plus or minus radiation. And if unresectable, then palliative chemo is the treatment of choice, and targeted therapy if available. Prognosis is very poor. Median survival rate is around 6 to 12 months from diagnosis. Complete resection may extend survival to 1 to 3 years in rare cases. And early detection, often incidental on echo, CT, or MRI, improves resectability chances. And high recurrence and metastatic potential is always there with this tumor, and it can metastasize to lung, liver, and brain. We are coming to case 3, the last case. This is the same case I presented as a poster yesterday, but there was, a little lack of information on the poster. So I decided to include the case in this oral presentation as well. So this is a 35-year-old male. He came with complaints of chest pain, dyspnea since 1 week, history of evening rise, fever, cough, and anorexia since 2 months, and he was a known case of early onset Parkinsonism. He was on multiple drugs for his Parkinsonism. On presentation, he had hypotension, tachycardia, tachypnea, muffled heart sounds, raised JVP. There were no significant STD changes except for the electrical alternance. The X-ray showed a cardiomegaly. This was his echo on presentation. As you can see, there is a massive pericardial effusion. These are the other views of his echo. We took him up for pericardiocentesis. On pericardiocentesis, there was the color of the fluid, and my MGIT, there was gene expert MGIT, everything was negative. There was nothing on cytology. Just neutrophil lymphocyte ratio was deranged, and ADA was also borderline 46.3. These were his labs. Just to note that he had hepatitis. So after we drained the fluid, we shifted the patient to ICU. After 4 to 6 hours, he started having progressive breathlessness in the ICU. And on review 2D echo, the EF had dropped to 20% with global hypokinesia and biventricular dysfunction. So this was his echo on presentation, and that was the echo post pericardiocentesis. So you can even visually make out that the EF has dropped. These are the other views of his echo. So there was a global LV hypokinesia, and yeah, this is the Plaques view. So the patient had no chest pain, no chest heaviness, no arrhythmia, serial tropies were negative, serial ECGs were also normal. But there was nothing that was suggestive of acute coronary syndrome. On his HRCT chest, it was suggestive of miliary Cox, and he had D10, D12 vertebral abscess, and it was extending from D2 to D12 as well. He had paravertebral collection. The patient was in cardiogenic shock, oliguric. He required triple inotropic support, non-invasive ventilatory support. Basically, it was a nightmare for us. And patient was hypotensive, hypoxic. He was not even responding to the triple inotropes. He was oliguric, going towards almost anuria. We were planning to dialyze him, but then there was no BP to dialyze him. ABG showed metabolic acidosis. There was a rising trend in creatinine. Patient was started on second line of ATT. Patient even had some skin lesions all over his body. The dermatology team was consulted, and they suspected tuberculosis of the skin as well. But unfortunately, patient and his relative did not give consent for the biopsy. So I could not include that in the presentation. Patient's relatives were counseled about the rare complication of pericardiocentesis, and they were told about the guarded to poor prognosis. This was his X-ray. So miraculously, after 48 hours on triple inotrop, patient started improving. He systolic BP around 120, 130 was maintaining. Creatinine started reducing. Inotrops were tapered, and his EF also improved to 55%. We did a CT coronary angiography, which was normal. Patient was off O2, and he was shifted out of the ICU. This was his 2D echo on discharge. As you can see, his EF had improved. Patient was discharged on second line of ATT and steroids. Patient is on regular follow-ups with cardiology, pulmonary medicine, orthopedics, and neurology. He is currently completely asymptomatic. Patient is prescribed 18 months of ATT. The orthopedics are planning to operate him uh, for the vertebral abscess, but currently the patient and his relatives are non-consenting for the operation. So this is a case of pericardial decompression syndrome. It is an ambiguous clinical entity which has generated controversy, which is regarding its existence. Paradoxical hemodynamic deterioration, that is pulmonary edema, LV dysfunction, and cardiogenic shock that occurs after rapid removal of pericardial fluid despite relief of tamponade. Incidence is around 5 to 10% of large volume pericardial effusion or tamponade drainage. Mortality is around 30% in severe cases. Risk factors are large pericardial effusion, malignant effusions, rapid complete drainage, pre-existing LV dysfunction, and pulmonary hypertension. Clinical presentation is usually it occurs within hours of drainage, acute pulmonary edema, hypotension, cardiogenic shock, new or worsening LV dysfunction on echo, occasionally arrhythmias. Diagnosis is clinical deterioration after initial improvement post drainage. Echocardiography, obviously it shows LV systolic dysfunction, RV dilatation or septal shift. We must exclude other complications of coronary laceration, tamponade reoccurrence or hemorrhage. Proposed pathophysiology for it is there are three theories. So one is a hemodynamic shift theory, that is rapid decompression. There is sudden increase in venous return, and there is RV over distension, which leads to LV compression, septal shift due to the septal shift, and LV output drops, and there is pulmonary edema. The second theory is myocardial ischemia and stunning. So there is prolonged tamponade, low coronary perfusion, subclinical ischemia, and rapid perfusion after decompression. And there is so because of that, there is transit LV dysfunction. And the last theory is autonomic imbalance. There is a sudden removal of sympathetic drive needed to sustain the output in tamponade. So then there is LV depression, pre-existing ventricular dysfunction. This is just a diagram that is given on the American Heart Association website. It shows the same pathophysiology. So the management of this condition, first and foremost, is the prevention. So there should be gradual fluid removal, especially more than 500 in the more than 500 ml of effusions. Leave pericardial drain in situ for slow continuous drainage. Close hemodynamic and echo monitoring post procedure. If pericardial decompression syndrome occurs, you should give supportive care, oxygen, non-invasive or invasive ventilation, and inotrope vasopressor for cryogenic shock, and diuretics for pulmonary edema, ECMO or mechanical support for refractory cases. And prognosis is variable. Some patients recover LV function within days, and some may die also of refractory cardiogenic shock. Prevention and early recognition are crucial. And to note, we should never aspirate large amount of effusions all at once. Always drain slowly, monitor closely, and anticipate pericardial decompression syndrome in malignant chronic effusions. So for discussion, these three cases emphasize the diagnostic spectrum and clinical variability of pericardial effusion. Each case demanded a unique diagnostic approach, highlighting the significance of pericardial fluid analysis, imaging, and clinical correlation. Cardiac angiosarcoma, though rare, should be considered in young patients with hemorrhagic effusions and atypical imaging findings. Early therapeutic intervention in infective cases, infective causes significantly alters outcomes, unlike malignant etiologies, which often carry poor prognosis. Tuberculosis and etiologies remain prevalent in Indian population and demand high clinical suspicion. Take-home message would be pericardial effusion in young adults warrant meticulous evaluation, early identification, and individualized management, especially in high risk or rare causes, can be life-saving. Never aspirate large effusions all at once, and rare etiologies of effusion must be actively sought in young patients with a recurrent or atypical presentation. Thank you.